Rural hospitals are community strongholds, serving as the key point of care for nearly 20% of Americans. Beyond providing healing and hope, rural hospitals nationwide are pillars of their local economies, creating essential jobs that support families and community vitality. The emergence of COVID-19 has created unprecedented challenges to the U.S. hospital system. As frontline responders, hospitals have significant responsibilities for identifying and treating patients with COVID-19. Hospitals around the country are adapting to the constantly changing face of the COVID-19 pandemic by adopting both expected and novel strategies to tackle the crisis. Welcome to Advancing Health, the podcast brought to you by the American Hospital Association. I'm Tom Petterly, senior writer for AHA. Recently, AHA published a compendium of case examples demonstrating the struggles and successes of rural hospitals battling COVID-19 in their communities. For this podcast, we honor our hospital heroes and examine how hospitals are surviving the surge of patients due to COVID-19. Today, we hear from Siri Nelson, CEO of Marshall Medical Center in Placerville, California. That's about 45 miles east of Sacramento.
Good day. I am John Supplett, Senior Director of Rural Health Services for the American Hospital Association. Today, we'll hear the story of hospital heroes caring for COVID-19 patients at Marshall Medical Center, located in the foothills of the Sierra Nevada mountains in Northern California. Marshall is a full-service, 125-bed, not-for-profit hospital with a Level 3 trauma center serving El Dorado and its neighboring counties. Siri, I know you're in the thick of the battle against COVID-19, and there's much our rural hospital colleagues learn from your early experiences. Thanks for taking the time to share your story with us.
I'm really happy to be able to do that, John. I'm honored to be a part of this.
Siri, I understand that you're preparing for an influx of COVID-19 patients in your community. Where do you stand now?
So El Dorado County is just east of Sacramento, and the entire county population is around 180,000 people. At this point, there's been about 1,940 people tested. 1,897 of them have been negative. So we've only had 43 positive cases in the entire county. Currently at Marshall Medical Center, we have 3 patients who are patients under investigation or suspected COVID patients, and we've only ever had 1 positive patient here at Marshall.
Great. Well, with dozens of confirmed cases across El Dorado County, with whom and how are you coordinating surge planning?
So surge planning has been a major effort at Marshall since we enacted our incident command system on March 16th. We've been coordinating with lots of other partners in the community, including El Dorado County, the Public Health Department of El Dorado County, UC Davis have been a great partner to us, Barton Health, which is the other hospital in the county in South Lake Tahoe, as well as the California Department of Public Health, CHA, and of course AHA.
So you're really reaching all along the counties around El Dorado and the communities all the way up to South Lake Tahoe.
Absolutely. We feel that it's our role as a community provider to reach out and cross bridges and lend our expertise. We are really looking at our clinicians. COVID-19 is not, it's not a fire or a flood or an earthquake. It's a clinical event, and so we are really leaning on our clinical providers to help us lead the way.
So how are you communicating this threat to the community? How are you making them aware of the circumstances around the surge?
So we have worked with our community partners. We have banners over the highway in Highway 50 that goes through the center of El Dorado County that say things like wash your hands and social distancing. We've sent out many, many messages on our Facebook page reiterating social distancing, washing your hands, being safe, wearing a mask out in public, and really trying to coordinate our message with all of the parties. So we're coordinating with the county as well as Barton and making sure we have a consistent voice for the entire community.
So then what steps have you taken at the hospital to prepare for a COVID-19 surge, and why?
So at first, we were really concerned about a massive push of inpatients. We had no idea how this was going to roll, how effective El Dorado County was going to be at social distancing and bending that curve down. And so our initial focus was really trying to figure out how many patients we could care for safely here at Marshall. So we worked with our ICU medical directors, we worked with our physicians, as well as our nursing staff to figure out how many ventilators we had, where would we put everybody, how many staff do we have. One of the things our medical staff office did is send out a survey to all of our physicians in our medical foundation, asking them about their inpatient skills, if they felt comfortable intubating and doing central lines and those kind of things. So we got a whole list of essentially outpatient physicians who were willing to come in should we have that surge on the inpatient side.
And what about inpatient services within the hospital itself? How have you made accommodations, or have you made any, with respect to the types of services that you're now making available in El Dorado County?
So one of the things we had to do was reduce our elective outpatient services. So we had, Marshall does a very large number of outpatient surgeries every month, and we ended up having to reschedule most of those to create space, partially because we didn't want to endanger the community by having them potentially infected by healthcare workers, and we also didn't want our healthcare workers by bringing in somebody who was potentially COVID positive. So anybody who wasn't an emergent scheduled procedure, we actually rescheduled them several months out to create that space until we could figure out how to do the testing, how to make sure that everybody was able to receive care safely.
And are you confident that you have the necessary testing supplies, the ventilators, the equipment, and the capacity to treat a surge of COVID-19 patients? And if you are, how did you improvise? How was that accomplished?
Well, that was part of our big plan, was trying to figure out what we could accommodate and what we couldn't accommodate. So I'm very fortunate that my chief medical officer, Dr. Brian Goldsmith, is a radiation oncologist by trade, but also loves data. And he has done a great job doing some data modeling for us on what the surge would look like, how big it could potentially get, and looking at our current data to see where we are in that curve. So we were able to say with some confidence a couple of weeks into the pandemic what we thought our curve number was going to look like. And it's essentially double our inpatient capacity. So if we're licensed for 125 beds, we were looking at trying to get to 250 roughly. And we ended up looking at our staffing, where we would put all those patients. UC Davis has been a huge partner for us on the testing front. The biggest initial challenge we had was that we had many patients here at Marshall who we suspected had COVID, but we were waiting for their test results. So they either went through the public health lab or to the commercial lab, and they would often take 5, 6, 7 days. And the challenge with that is you have to treat these patients as if they're COVID positive while you're waiting for that test result. So we were using a lot of that personal protective equipment during that time. UC Davis reached out to us and said they were having in-house testing and was able to provide that service to Marshall. So now we can get a one-day turnaround on those suspected COVID patients so that we don't have to burn through our PPE, and we can actually have those patients cared for in the way that they need to be.
So your testing, your ability to test and the capacity to test has changed the landscape in the way in which you can care and treat patients.
It absolutely has changed the landscape. It's made a huge difference for us to get that rapid turnaround. We're still looking at point-of-care testing. We're also looking at being able to do our own in-house testing. UC Davis, as I said, has been a great partner, but they have limited capacity as well, and so we only have the ability to do 25 of those tests a week. And so far, that's been adequate, but we want to make sure that if we get a surge, we can continue to be able to test everybody who needs it.
That's fantastic. So if you could tell me, Siri, how have you had to adjust staffing between the hospitals and your clinics under your emergency planning for the COVID-19 crisis? And if you could, be specific.
Sure, I'd be happy to. So Marshall has many outpatient clinics scattered all over El Dorado County. And the first thing we did was sort of consolidate the clinics to central locations, because what we wanted to do was make sure that anybody who came into the clinic, any patient that came in for a primary care visit or a cardiology visit or whatever they needed got screened prior to being into the clinic. So we have tents out in front of the clinics where patients are screened ahead of time and masks before they go into the clinic to see their provider. So that was one thing we did. The other thing we did is our anesthesiologists have actually volunteered to be our code team, so that anytime we have a code blue on a patient who's suspected COVID, we have the anesthesiologist available 24/7 in-house to be able to do that for them. And they know all about the protective equipment and making sure that they're safe and the patient's safe. And we've really had to sort of readjust things. One of the things that I think is a little bit unique is we opened up a nursing triage line here at Marshall, and we have our Kaizen department, which is our process improvement department, and the head of that department, Janelle Montgomery, is an RN, and she actually, because we're not doing a lot of we're doing a lot of rapid process improvement, we're not doing formal Kaizen events, and so Janelle had some capacity, and she was able to actually take over the call center and doing the triage line. And it's really nice to see people sort of get out of what their normal job is and get into other things and help out where they're needed.
Sherry, the foothills of El Dorado County are hilly, it's forested, it's rough terrain. Transportation can be an issue, and many of your residents are elderly. They're reluctant to seek care at the hospital or clinic. So what are you doing to meet the needs of those who are more isolated?
That's a great question, John, and I think we've done a lot of things to try and help that. So one of the things is we immediately started doing telephone clinic visits so that the provider can actually talk to the patient at their home. And first it was just telephone, and they were able to screen them and make sure they're taking their medication and ask them how they're doing. We are still doing telephone visits, but we're also now doing video visits. We're using two different platforms. One is the MyChart app of Epic, which is our electronic health record, and the other one is another app called Doxy.me. And we're using both of those as a trial to see which one patients can use more easily. And I have to say the patients really love the video visits. And one of the little positive things that's coming out of all this is that rapid process improvement. And I think now that our patients have had access to video visits, that's not going away. And we're trying to figure out post-COVID how we're going to put that into our process flow to make sure we can continue to provide that service for patients.
So you're pleasantly surprised with the way in which your folks have assimilated to the video and telehealth visits.
Yeah, they've loved it. All ages, it's been really super easy. They get to see their provider, and I think it's really helped improve their confidence in how they're doing and the care that they're receiving.
That's fantastic. So can you tell us the kind of impact that COVID-19 has had on the hospital's business and how you're managing the changes in volume and the lost revenue?
Yeah, that's a major concern, John. I think we looked at, like I said, we implemented Instant Command the middle of March, and our March volume was down probably 15%. We ended up having a significant operating loss in the month of March. And I will tell you, the last time I looked at April data is we're down 35% on net revenue, which is a big number for us. We're not going to be able to flex our expenses by that amount of money, and I know we're going to lose money in the month of April. What I'm hoping is that as we start to loosen things up and start bringing some of that elective care back, that May will look more like March did and April will be the trough, but we don't know yet. So one of the things that we've been doing is we did do the advance payments for Medicare. So we applied for 6 months advance payments. Right now we've received about half of what we think we should get, and we're working on with that with our fiscal intermediary. We did get about $5.6 million of CARES Act funding, which was amazingly helpful. So that was a big help. The other thing we've done is we've had to flex staff. Marshall has a program called work reduction. So essentially, staff are home. They can either take their paid time off or take it as unpaid time. And we've had to work reduce a number of employees. And we're keeping them all on benefits. We're not calling it furloughs, but it is significant work reduction, and so their paychecks are going down. So I feel for our staff, and we're trying to do everything we can to help support them and maintain the business. The other thing that Marshall just did, in fact, it just closed yesterday, was we just issued bonds. The bonds have been on our strategic plan for the last year or so, and the timing worked out that we actually were able to issue them a couple of days ago, and included in the bond issue is about $27 million of cash for things that Marshall has already spent that will refill our cash coffers. So at this point, my main focus is really just cash. The income statement's going to do whatever the income statement's going to do, and there's not a whole lot I can do about that. But what we're trying to do is get enough cash to weather through the storm so we can get through the other side of this.
I hear you. You're making a lot of hard decisions that are affecting the lives of your staff and your community. Where do you see this crisis heading, and when do you expect to return to normal?
Well, like I said before, I think El Dorado and broader in California, specifically Northern California, has done a really good job of shelter in place and bending down that pandemic curve that everybody was so scared to see. So I think that we are going to start slowly opening. The governor in the state of California is already amending some of his stay-at-home orders. El Dorado County is actually meeting right this minute to discuss a letter to the county or to the governor to request reopening specifically for El Dorado County. So I think it's going to be slow. I think what gives me comfort in that is that we're doing the right thing to care for patients, and we also have that early warning system because of all the great data analytics that Dr. Goldsmith has been able to do, that if we start seeing COVID picking up again in our community, we can go back and say, okay, we need to slow down again. So it's not going to be a hard on-off. It's going to be a slowly opening up and a methodical approach to let's see what happens when we do this. Let's see if we get any more cases. Let's see how we're doing on social distancing. And then as things improve, we can open up a little more. And if they get a little worse, we can dial it back a little bit.
Well, it sounds like you've got a lot of confidence in the plan that you've got in front of you and that it's working as well as it could. Let me ask you, Siri, one final question. What advice can you give your colleagues that will help them prepare for COVID-19?
Well, that's a great question, John. You know, I was really thinking about how I was going to answer that, and I think the big thing I want to say is focus on your leadership team. And I've really been working hard with them to support them. Burnout is a real issue. Just because you're an executive does not mean you're immune from the fear of COVID. And I'm really working with my team to make sure that they feel supported, that they're taking time off, that they're practicing self-care, that I'm giving them space to be able to talk about their fears or their personal lives or whatever's going on with them, to be able to really be vulnerable and be human in front of everybody else, so that we can show up to be the best leaders we can be during this trying time.
Well, Siri, I think Marshall Medical Center is gifted with some great leadership, and I can hear the compassion in your voice. So I wish you the very best as you continue your battle against COVID-19. And the strength of rural health care is critical to the fabric of American health care. And it is our mission to safeguard it, improve it, expand it, and advance it for future generations. Thank you to our country's healthcare providers for their hard work, dedication, and sacrifice in this trying time. And thank you to the hospital and health systems leaders like Siri Nelson, CEO, and the nurses, physicians, and all healthcare heroes caring for patients at Marshall Medical Center in the foothills of the Sierra Nevada and across rural America. This is one of several stories of how rural hospitals are rising to the challenge of COVID-19. Visit www.aha.org to access these and other COVID-19 resources available to hospitals and health systems. I am John Supplett. I hope you enjoyed the podcast. Be safe and stay well.